All right, so first let me just introduce myself. Thank you, Cha, for the initial introduction. My name is Rita Sembajwe. I'm a global public health informatician with RTI International based in Atlanta, Georgia in the US. I primarily work with teams to integrate digital health solutions within health information systems ecosystems. So in particularly low resource settings with the goal of increasing access to high quality health data across a country health system. I'm also a member of the OpenHIE community of practice. I'm the co-founder of the Laboratory Information Systems sub-community within OpenHIE, along with Jan Flowers of the University of Washington, which some of you may know. And I'm one of the co-hosts of the OpenHIE Facility Registry community, which is why which is what brought me here today. So I know I don't have a lot of time, so what I'm going to try to do is provide you with a bit of an overview of the OpenHIE community, facility registry community, and a little bit about what a facility registry is and why it's important. So I think most of you are familiar with OpenHIE. It is a community of people, experts, building an open framework to support nations as they develop health information exchanges. The OpenHIE Facility Registry community, which I'm a part of, is one of the many communities under OpenHIE. And a fun fact about it is it was the first community that was actually launched within OpenHIE more than a decade ago at this point. And a lot of the early guidance a lot of the early guidance and resources in the community came from one of the first facility registry implementations in Tanzania. That's in East Africa. The facility registry community aims to support the development and implementation of technologies for health facility registries primarily. It serves as a space to share guidelines for facility registry architecture development. It supports those seeking guidance on implementation of facility registries, and it serves as a platform to share lessons learned through showcasing how country-level facility registry implementation occurs. We have quarterly meetings where we welcome community members to have technical conversations about facility registry architecture, or share lessons learned about how their registry implementations are going, challenges they may have encountered, unique solutions that they've come up with for their unique and implementations of a facility registry. We even and actually especially enjoy welcoming those who want guidance on where to start to integrate a facility registry. And our members comprise of system architects, health informaticians like me, digital health implementers, and we have representation from an array of organizations, including NGOs and government agencies across the world. So really, we welcome all health facility registry enthusiasts and experts. So our meetings occur in the last month of every quarter. So we only have meetings quarterly. And they occur on the fourth Thursday of that last month in a quarter. And you can track the schedule for our meetings by checking our wiki page. And OpenHIE also has a discourse forum where the facility registry community posts when a meeting is upcoming. Okay. So what is a facility registry? OpenHIE states the purpose of a health facility registry is to act as the central authority to store and distribute an up-to-date and standardized set of facility data. Okay. It's important to understand the difference between a master facility list and a facility registry. So while a master facility list, or an MFL for short, is the complete, up-to-date, authoritative listing of facilities, serving as the primary source for which other facility lists in a country are drawn from, a facility registry can be understood as the technology, so the software, the platform that manages and shares the facility data in a master facility list, allowing it to be used by other digital health systems within a health information exchange, and also making facility data accessible to the public, to health workers, depending on how a country wants to use the data. So why a health facility registry? So basic data in facility lists are often spread out across multiple systems, or housed by multiple agencies, ministries sometimes. And health facility registries allow you to bring all that important facility data into one location, and dispel or get rid of the disparate lists that are floating around. Facility list data is often out of date or slow to be updated. Okay. Facility registries provide a central point to access that facility data so you can update it easily. And often facility registries provide functionality to curate or manage how health facility data should be updated and kept current. You can have a workflow in place in a country where the national level has officials that review whether facility data needs to be updated, but also the subnational level, down to the local level, has some responsibility in accessing the facility data and verifying that what needs to be updated is accurate, or what's been updated is accurate. Facility registries often accommodate that level of updating and curation. Facility list data often sits, like I mentioned, in very disparate digital health systems that do not have common IDs or APIs, making it hard to exchange data between information systems that exist within a health information systems ecosystem. Facility registries typically operate as part of a health information exchange, using standards to funnel, or APIs to funnel data between systems, and offer common ID that can be used to exchange that facility data. And then ultimately, facility registries provide quick access to key facility data, such as facility unique identifiers, contact details, geolocations, facility ownership, operation status, services available at facilities, and even information about architecture. So OpenHIE has architecture specifications that provide what you could call mandatory and recommended facility registry workflow and functional requirements. I'm not going to go through all of them because I'm almost out of time, but what I want to show you, I just clicked on a link that takes me to the OpenHIE architecture specifications page. And what you're seeing here is a listing of those requirements. You'll see we have one workflow requirement to support the querying of health work and facility registry, facility records, but then we have 14 functional requirements, ranging from the minimum set of attributes to supporting multi-organization hierarchies, allowing pull and push of data, all of that, all the functional requirements you see here range or run across those categories. And then you have non-functional requirements that are primarily revolve around the standard means of access, the presence of documentation, availability of source code and configuration. So all those things associated with a software, facility registry software. And lastly, this is just a display of some of the OpenHIE reference technologies that have been used to develop facility registries that we know of, or that provide core facility registry functions. You can find information about these technology platforms on the OpenHIE wiki page, and obviously Google them and probably find a direct website that offers this information. And in fact, some of the presentations today you will see have used some of these or a combination of these software. So on that note, I'm going to stop here. Thank you very much. And my email is on my slides if you want to reach out to me to ask more questions about OpenHIE's facility registry community, or even where to start with your own facility registry. I can hopefully direct you to some of the right experts. Thanks so much.
Thank you for taking the time out to join us here, Ms. Rita. Now, I would like to call on our next speaker, Mr. Biruhtesfa Abere, who will talk about Ethiopia's facility registry integration journey.
Okay, thank you very much. It is a pleasure to, share our experience to AHIN community, and we believe we have been doing a lot of activities in terms of adapting and scaling up the master facility registry in Ethiopia. And yeah, I'll be presenting that to you, and I hope it will be beneficial for you all. So before I jump to the details of my presentation, I want to give you a little bit of background about demographic information of Ethiopia, and which is actually relevant for this presentation. So Ethiopia is a very big country located in the Eastern Africa, and we have an area of 1.1 million kilometers per square. It's actually the 10th largest country in Africa. And we have a huge population, and it's the second population in Africa, which is actually more than 120 million. And we have a huge number of public health facilities, more than 17,000 health posts, more than 3,000 health centers, and around 300 hospitals. And by looking this figure, you can actually tell why master facility registry is important for a country like Ethiopia. So the project we are working is called this USAID Digitalization activity, and it's implemented by GSI. It is actually a flagship project for the USAID. It is based in Addis in Ethiopia. And this project is actually inspired by the pillars of information revolution, which is one of the key agenda of the Ministry of Health's Health Information Transformation Plan. And the Information Revolution Plan have these pillars, which is similar to our project. Our project actually inspired by the Information Revolution pillars, which have digitization, data use, capacity building, and governance. And the digitalization aspect of the pillar actually is responsible for adapting, customizing, piloting digital tools, and to hand it to the implementation team, and the implementation team scaled up the tools. And our data use team actually is responsible in ensuring that the data coming out of the system will be used for decision making and intervention, and they will also work in improving and bringing the data use culture among health workers and decision makers. And the last pillar is called capacity building, and the capacity building pillar of our project works in ensuring that to place electronic learning platforms so that we can have health workers across the country follow up, learn, and upgrade themselves using these e-learning tools, so that we can disseminate the information in the trainings with a lesser cost for all health workers across the country. Okay, so what is the development and adoption journey of the Master Facilities Registry in Ethiopia? In Ethiopia, we had former version, which we used to call it a version 1, and we have the current and active one, version 2. The version 1 was initially developed by the partner called Instate, and they actually used a different tech stack back then. It was before 2018. And after that project actually phased out, GSI took in, there was another project called Earth-Free, and back then the version 1 was developed by taking over what Instate actually started. And back then it was based on a resource map, the version 1 for the backend. So there was actually a lot of issues reported in using the resource map back then, like saying there is lack in performances, and there is an issue in capturing the actual requirements, in addressing the intended requirements of the Ministry of Health and of course stakeholders. And because MFR is a key digital tool within the e-health architecture, and it needs to be user-friendly, it needs to be interoperable, it needs to be a system that shares facility data efficiently and effectively to other subsystems. And we had to change the backend to HappyFire, which is a data exchange, an HL7, one of HL7 standard to share and exchange data among digital health tools easily. So with the project that we are in currently, the digital health activity actually changed and developed version 2, which is actually now launched and in use across the country. So to give you a little bit background about the tech stack, the version 1 uses the resource map, and for the front end we used Angular, and we have been using MySQL, and we used .NET Core as a framework to organize every data sharing and presentation within the system. But now we have changed this by using HappyFire, and still we are using .NET Core and Angular for a backend as a framework and for the front end. But we changed the MySQL to Postgres database. So this is just to give you a background about the tech stack. So what actually drive Ethiopia to have or to adopt Master Facilities Registry? And there are actually a lot of reasons or justifications to have the facilities registration, but these are actually the top of the list. So we believe that it will bring enhanced patient care, and that's actually one of the reasons we adopted the Master Facilities Registry, because any healthcare provider can quickly locate nearby facilities, and it will also facilitate referrals, which actually links to enhanced or improved quality of patient care. The other one is improved data accuracy and better visualization. Of course, having a proper facility list and quality data on facility shows a consistent and error-free data visualization. We can also map out all data based on each facility within that registry. So these are the two things that actually drive Ethiopia to have the Master Facilities Registry. And the other one is efficient resource mapping, because the Facilities Registry have different data sources that shows about the facilities, equipment, services, infrastructure, healthcare providers, and so on, which actually later on provides decision makers, stakeholders, donors, funders to align their resources and map and properly allocate intended resource at each health facility. The other core important aspect is interoperability. As I've tried to mention earlier, the Master Facilities Registry plays the crucial role within the e-health architecture, which I will talk about on my later presentation or slide. So interoperability is very important, because we don't want every subsystem within the health architecture to worry about health facilities registry, and we will have that a master list of facility that will actually provide this list to all subsystems within the e-health architecture. So these are actually the main reasons behind adapting the Master Facilities Registry in Ethiopia. So this is actually our e-health architecture. I believe most African countries have similar e-health architecture, and we have different components within this e-health architecture. We have the institution-based data subsystems, we have the population-based, we have analytics and BI, we have interoperability, which we use OpenHIE as a mediator, because it is actually endorsed and selected by the Ministry of Health itself. We have the point of care systems, we have the external systems, and the shared service, which is where the master facility registry actually placed in. And with this structure, this e-health architecture actually provides a blueprint for all interoperability developers to envision their development based on this structure. The Ministry of Health highly enforces every interoperability developer, digital developer, to align with this e-health architecture to develop every system that's related to health. So MFR is scaled up in use. We focused on service and signature domain. Actually, we don't have much of data on signature domain. I will talk about that later on. And we have 43,000 facility data, with many of them with geolocation. And this includes actually private and public health facilities. So the key functions of the MFR are multiple and have like amazing features. And the first important one is the service and signature domains. It houses data about facilities, services, equipment, infrastructure, and so on. And it also shows and allows to view facility management, administrative units, and it have impressive dashboard functionality, which actually provides insights and data points for important decision makers at all levels. And of course, the interoperability with it is ready-made API for data sharing among other subsystems, thanks to the FHIR technology. So facility registry alone is just nothing. Building the system alone is just nothing. The most important piece of facility registry is having a quality data in it, right? So this is actually also one of the, the difficult part of the job, developing and scaling up MFR, because in a country like complex health system and a huge country like Ethiopia, it's difficult to have even a good source of facility registry to start with, right? Because we are starting facility registry after many systems are out there and the health system is out there and so on. So we have to start from somewhere. So one of the data sources we used was DHIS2, because DHIS2 is implemented at large at many facilities in the country, and it is the main and crucial health information management reporting system for the aggregate. And this is a very important system for the Ministry of Health at national level and as well as subnational level. So it have like relatively the best quality of facility data. And we use that as a data source to initialize the facility registry system, because we have to populate facility lists. So we actually later on used to reconcile, assessments like SPA assessments. We call it SPA assessment, service provision assessment, the SARA assessment, service availability and assessments, because they have like facility data. And we use the National Central Statistical Agency. This is the CSA, where they do all sorts of assessments, statistics and so on, because they have list of facilities for the health system. And we took all data in, we sat down together with the regulatory body, and we had to do reconciliation, which is a very, very tiresome process for us. And we use logistics management information system, all systems that was built previously before the master facility registry, used as a data source for us. But still, we haven't yet populated effectively the service domain data, because it needs a huge interaction from all regulatory bodies across the board, right? From health facilities, districts, zonal offices, and so on, need to be participated to maintain service data. And previously, up to now, we have been focusing on signature data. And we tried to send out regulatory body and health workers to collect data using ODK service domains, because we don't have that in any of the systems like DHIS2 and CSA. And yeah, recently we actually tried to develop another system called facility licensing, which actually will allow us to maintain quality data within MFR, because we want every data within the MFR to be approved, clean, and acknowledged by regulatory body of that area. So this facility licensing is very promising for us in maintaining quality data. The other important piece of the MFR successful implementation will be having a proper and ideal governance structure and document. And with this, we have this governance document actually endorsed by the Minister of Health, and it have multiple components. The first one is governance structure, which actually lays out the administratives within the Minister of Health. The first one is the Joint Steering Committee, which is being chaired by the Minister of Health itself. And there is an HIS advisory group, and we have the MFR technical working group that actually reports to the advisory group, and the advisory group sends out reports and presents the status to the steering committee. And we have actually laid out roles and the responsibilities at national, subnational, and district level, because without this, it's actually difficult to maintain quality data across the board. So we have three critical or key directorates within the Ministry of Health, and as well as regional health bureaus, and as well as district levels. We have regulatory body, we have digital health directorate, we have strategic affairs, and all have their own responsibilities and roles to maintain quality data and ensure MFR is properly used across all stakeholders. And most importantly, it also lays out the data content. What do you mean by service domain? What do you mean by signature domain? It's actually put together into the governance document. And when we say the signature domain, it constrains facility type, ownership, like those data that cannot be changed by any means, right? Geo-coordinate, unless it is like moved or changed. So the settlement and on and so on. So the other one is the service domain, which is actually changeable: infrastructure, number of beds, rooms, water supplies, and so on. And we have the workflows that actually lays out adding, updating facilities properly. And this document actually is very important and disseminated across all stakeholders of the MFR in the country. So we have also dashboards, which I actually mentioned earlier as a functions of the facility registry. And this dashboard, these components actually extracted from the dashboard itself. And this actually shows ownership type, facility type, settlements. It shows like more than 24,000 facilities are in the rural area, and you have 19,000 facilities within the urban, and so on. Source of power. And we also have this map, because we have geolocation data within our MFR system, and it shows their location, distance, and so on. So one of the key important of having this master facility registry is like to do a data source for other subsystems, right? And we have actually prioritized and working on multiple use cases to integrate master facility with other subsystems. So the one that we have actually finalized is integrating MFR with DHIS2, because previously DHIS2 was the source. Now it is flipped, and we are actually trying to scale up developments completely and trying to scale up that. Moving forward, we're going to be using MFR or facility registry as a source of data, including DHIS2. And we have prioritized logistics management system and EFHIS to be developed in the future. Last slide, it's about lessons learned. And we learned that local capacity is crucial, especially within the Ministry of Health at national level and subnational level, to ensure ownership and sustainability, because as you know, most of the initiatives are led by partners, which actually works within the span of a project, and we need to be able to ensure ownership and sustainability. And that is one of the key lessons we have learned. The second one is proper technology choice is important. We need to consider all requirements, needs, the country size, facility size, and so on when we choose technology to build the facility registry. And these are the key lessons we have learned. And level setting with all stakeholders at all levels of the health system, ensuring that the governance and policy document is acknowledged by all stakeholders at all levels of the health structure. So this is my last slide. Thank you very much.
Thank you very much, Sir Biruhtesfa. So now we'll be proceeding to the next presentation. It's on Sunbird RC platform-derived facility registries in India and Sri Lanka. To be presented by Ms. Priyanka Yadav.
Hi everyone, good evening from India. Today basically I'll be talking more about Sunbird RC and how it can be leveraged by countries as an open source certified digital public good for fast tracking development of registries and verifiable credential associated with those registries, and how this has also been adopted and done multiple pilots within India, and Sri Lanka is in the process of adopting the same framework and building their own health registries. So I am an associate director with Deloitte. I am also a volunteer with Sunbird RC and Beckn Open Collective, basically focusing on open network and registries, which are sector agnostic. So I will not waste a lot of time on why do we need it, but the core framework or the core principles why we thought we should build Sunbird RC was any digital health system, or for that matter, any digital transformation requires three things in place to make it very inclusive. One is digital identities, basically identifying each stakeholder uniquely. This is where registries come into place, and also you can augment trust or build more trust in the healthcare delivery if we are also able to verify those entities via verifiable credential. Digital assets, why? Because every stakeholder can have a primary ID which comes out of the registry as an output, which links not just for patient, linking all their scattered medical records in one place and harmonize it in a PHR framework. It is also with respect to the health professional, enabling them to provide services which are portable, not bounded by geography and licensing authorities in just one geography. Third is, can we also bring in trust in digital transactions? So whenever I generate a PHR, a e-prescription, or even a COVID-19 certificate, if you remember, we have done that, multiple countries have done that, including Sri Lanka. Can we also bring in trust and augment trust there by enabling verification, verifiability via verifiable QR code? So all these three learnings from the past we had taken, and that's how Sunbird RC architecture was built. So Sunbird RC basically has two key components. One is the component, the framework, which is a low-code, no-code framework, which enables countries to build electronic registry, fast-track development. You don't have to think from scratch or design from scratch. All the basic functionality a registry should enable, right from registration, setting up the schema, registering entities, deduplication, bulk upload, individual self-registration, having a public portal to discover facilities and health entities via the government, enabling it for citizens, to also attesting the claims. You can verify a facility, you can verify a patient, you can verify a health professional, and also issue verifiable credentials or licenses to the professional and health facilities, thus by bringing in more accountability and more trust in the healthcare delivery. That's the electronic registry part. The VC part, the verifiable credential part, that's another module that RC has, which basically focus on enabling or issuance of verifiable credentials or QR code, very similar to what happened in COVID-19, where Sunbird RC was a core component of the DIVOC DPG, which was implemented by 7 countries and enabled fast-track issuance of COVID-19 certificate, which were offline and online verifiable. So we have incorporated the same component here, not just registry, you will also issue. So registry will act as a single source of truth. Along with the registries, the authorities can also issue verifiable digital credentials, which cannot be edited, muted, thus bringing in more trust and control in government and enabling safe healthcare for citizens. So just a brief on Sunbird RC. Sunbird RC is a certified DPG by DPG Alliance. It's basically a fast-tracked or low-code framework that enables rapid creation of electronic registry, issuance of credentials, and also enabling verification services to enable verification. It also has a open source e-locker framework that can enable storing of those digital credentials, whether it's for health professional or a facility or even identity, can be stored at one place, linked to the unique IDs that all again harmonizes and synergizes the multiple records or licenses I as a practitioner may have tomorrow. And it's highly configurable, it's extendable and modular in nature. That means the country has an option to choose Do I only need to use the registry component? Do I only need to use the VC component? You can plug and play with any existing health system the country may have, or any existing digital ID system the country may have. It is completely API enabled. It is the VC component is W3C compliant. So we have taken care of standards from the very beginning. So these are the basic functionality that this framework enables. You can enroll an entity, a stakeholder, with the minimum defined schema, schema that the country decides as per their policy. It's highly configurable. You can create schemas, you can publish schemas, and that there will be a front end that you may have to build that will help you enroll the entities as per your required workflow. Again, the workflow can also be highly configurable. It also has authentication services that basically helps these stakeholders, government entities, or verifiers to authenticate. For example, if I bulk upload number of facilities that I already have, which normally happens when you have to do a retrospective data management or migration, right? There should be verifier on the ground who can authenticate use these authentication services to basically verify the entity in picture. Maybe you can do it via ground verification by the health departments on the ground, or can also be an online authentication. Every time you add, so it's a maker checker flow. Every time you add a new facility or a new health stakeholder, somebody can verify and approve the addition that you may have done. Consent, again, it's basically when you share a facility data or when you are trying to share a patient data. So I'm a doctor, I want to go through the longitudinal health record linked to the patient ID. I may want to enable consent, that can I share it with somebody else? Can I access your record? So it also enables consent, that the actor approves of sharing its information to an ex parte, an authorized ex parte. Attest, again, for example, if it's a health professional, he needs to be onboarded in a government program or a facility. You can attest, he can self-attest and submit that this is a verifiable credential that I have, this is my license of practice, and it can be attested by an authority by just verifying the data and the certificate ID involved. You can claim, again, and discovery. Discover is the public, maybe discovery. There are multiple APIs that Sunbird RC enables that helps easy lookup, that enables easy lookup, elastic search to discover an entity. It can be a facility, it can be a doctor. At the end of the day, I can create analytics and dashboards on top of it, that I should, at any point of time in a emergency situation like COVID-19, I should know how many resources, health resources I have, whether they are health professionals or number of facilities which are operating. Or tomorrow, if we go to a level where you also maintains subset of databases around bed management, you will also be able to discover this facility has these many bed available if you just want to use the lookup API. And update, like every record for a registry to be maintainable, sustainable, and update function is very, very critical, that a health authority can keep updating the data as and when required, which again gets verified and approved in the framework. So I'll just skip that. This is the basic flow that Sunbird RC enables. You define the schema. After the definition, when the system goes live, you configure the workflow. You onboard a user. First, you create user roles depending upon the policy that you have or the design documentation that you may have. There are two components. You can do a self-registration or a one-on-one registration of the entity in question, or you can also do a bulk upload, which may be approved by the authority or identified users in the system. Because there is a lot of retrospective data that has to be deduplicated and issued a unique ID. So there are two ways of doing it. You can leverage, if your country already has unique IDs for the facilities or professional, you can create a placeholder to store that unique ID. Or the Sunbird RC also enables you to configure an identifier service where you issue that identifier to a uniquely added entity in the registry component. Once your registries are established, you can initiate the VC issuance components where you can issue a patient card. So I have a unique patient ID which will give me portability of my health across the country. I may go to any place, that unique ID and that credential will help the facilities to access requests to my longitudinal record, access requests to my demographics, etc., etc. Same goes with the credential that may be provided to a professional. I can give a proof of point that, okay, this is a certified professional verified by the government who is providing you services. And this verifiability components like a verifier, a universal verifier, SDKs are available that can be built on top of it, which enables offline and online verification of entities. And then there's a wallet component where you can store these digital credentials attached to the registry entity, which can be verified, shared, and make it more portable for multiple use case scenarios in healthcare. I won't go so much in detail. All the details about Sunbird RC backend is provided on the website, but this is what the high-level architecture look like. Elasticsearch is something we use for all the lookup APIs, and there are registry core components. There are multiple APIs that we use. So I won't go. I may park it for maybe a later conversation if we have to get into detail of the architecture. I'll also kind of skip this because there's again a tech architecture. So one of the pilot that we did, registries are not just limited to the facility registry or patient registry or a practitioner registry. There are other use cases that are also doable with Sunbird RC. So we did a small pilot with India's National Health Authority, where we tried to build registries for organ donation, because there are a lot of fraud cases, smuggling, unauthorized export of organs in the organ donation world. So that is where we may need single source of truth. We may need running live registries of donors available, of cadaver donors available, live recipient registry. So we did a small pilot. We started with the very basic registry, which is a pledge registry, which helps the citizens to take pledges on sharing their on basically donating their organs. And there were plans to have further registries also in place, which will take care of the entire organ donation cycle at a country or state level. The state can have their own organ transplantation system that can plug into these registries and derive waiting list and dynamic matching of pairing of organ donors as well as recipients across the cadaver registry as well as the live donor registry that are available. So this was one use case we did with National Health Authority and NOTO as a pilot project. The pledge registry just got launched a few weeks back. Second, the Sri Lanka Health Registry, Sri Lanka was the first few countries who adopted DIVOC for COVID-19 certificate, and Sunbird RC was a core component of DIVOC. So Sri Lanka was exploring how to basically, right now, they may not have more number of facilities, but they have registers, either physical register or Excel sheets maintained for by the health department or MOH for all the health facility registry. They also have a national health facility ID that they have. So the architecture that they figured out is that, okay, one, they will need a bulk upload functionality with all the HIN numbers acting as the unique facility ID number maintained in this registry framework. Second, they'll require a self-registration that the facility managers can self-register their facilities, which can be approved by an authority, because most of the health services are provided by public sector even today. The third, there was a verification flow where once you enter the health department or a user identified at a regional level provides the data or the data gets uploaded, there will be verifiers from MOH who will verify the facilities, health professional, etc., and approve the same and issue a unique ID. But unique, because they already have unique IDs in place for facilities, they already have the professional IDs from their medical registers. What we thought, let's not create a front end of a unique ID, but there will be a backend number that will remain unique, linked to the current identifiers that they already have, making it more robust and also let them handle the past data effectively. So this is something that Sri Lanka is currently in process of building. ICTA is working with MOH to develop the entire framework right now. And some of the other use cases where Sunbird RC has been used or can be leveraged is basically issuing verifiable skilling certificates to health workers, like skill badges, where you train them on a scheme on a platform, and you give them certification badges, which also acts as motivating the health workers to do better and learn, participate in more programs. As for example, in India, a lot of health workers are paid on the basis of trainings they do. So their direct benefit transfer is directly linked to a VC badge, which is verifiable to ensure that the person has done this training, and now this person can be onboarded into a particular government health scheme. Other than just these two registry and VC examples, Sunbird RC was utilized as part of DIVOC and had generated 2 billion plus verifiable certificates, which were maintained in a digital certificate registries. That tomorrow, if earlier there was a plan, if tomorrow WHO would have built a PKI infrastructure, the public key, private key can be stored and can be accessed for a cross-border verifiability as well, because it was all offline verifiability enabled by Sunbird RC there. So yeah, some of the major use cases. The more possibilities than Sunbird RC can be leveraged or looked at by countries as a fast-tracking, low-cost framework, because it's completely open source, available on MIT license, are issuing credentials, maintaining a health worker registry, maybe maintaining health skill badges, vaccination certificates for an end-to-end program tracking, and beneficiary registries and credentials. And these are some non-health use cases on your right-hand side that you can see. So I don't know if Q&A can be shared here, or I can answer them later. Maybe write an email if people have any questions. These are the QR code that you can just scan and go to the website and the wiki page that Sunbird RC has, and can also look at your respective countries to maybe leverage this framework for fast tracking registry and VC component development in health.
Thank you very much, Ms. Priyanka. Now we'll go to the last presentation for tonight. It's on GeoPrism Registry implementation in Lao PDR with Dr. Visith and Ms. Rica.
Thank you. Yeah, my name is Visith, Director of Center for Health Statistics and Information, Ministry of Health Lao PDR. I would like to present GeoPrism Registry implementation in Lao PDR. For this one is supported by GeoPrism organization in Lao PDR. This one is referring to the digital health strategy for Lao PDR, what established in so far. The strategy is for the 2023 and 2027. This is first strategy for health strategy in Lao PDR. The purpose is the making use of a health facility master list with a unique facility identifier for each health facility to ensure the data quality when collecting data from multiple systems for the better resource management, improve national health insurance financing. For health facility master list is cover all public health facility managed by the Lao Ministry of Health. For this one is we started to establish is in 2019 and endorsed in 1921. Start developed by Department of Planning and Corporation so far, but right now the department to be the Department of Planning and Finance and Department of Healthcare cooperate together to develop this by supported from WHO Laos in Laos. For this one is the cover of public health facility as a hospital in central, hospital in provincial, hospital district, including as a health center and laboratories. Each health facility is assigned unique health facility identifier, health facility type, English and Lao name, long and short version. Why no official romanization standard for the Lao script is available yet? The English name have been temporarily standardized, used and information system developed by the Special Lao Country Office for this system. For more update, mechanism was developed to ensure the health facility master list is appropriate to maintain. You can see the example is the form we developed to update to the list requested by provincial health office through a formal request letter and form. When some facility in district or in province, they need to want to change the name. Sometimes we already set the name, but the name could be changed. If they need to rename, they have to request us. The request form will designated staff by our center to review and approve this request and then update the health facility master list accordingly to GeoPrism Registry and synchronize with other system. You can see that one is the example is a form to the facility when they needed to update. Yes, this one is the detail for the common georegistry. So I would like to Rica, please continue to present for this one in detail.
Thank you so much, Dr. Visith, and my apologies first for my very hoarse voice because I've got a bit of a cold. But just to briefly introduce myself as well, my name is Rica Zamora Duchateau. I'm a technical advisor in digital health with Chai Laos and kind of have been here with the organization for 3.5 years, almost 4 years. And yeah, so Dr. Visith has walked us through kind of like a bit of background about the health facility master list in Laos and the SOP that was developed alongside it, kind of to ensure that the list is appropriately maintained. And I know we've had some fantastic examples from Ethiopia and Sri Lanka about facility registry tools. And before I go into detail about the GeoPrism Registry platform, I'd like to explain a bit more about the concept behind it, which is called a common georegistry. So as you may be aware, within health and also across other sectors, there are other master lists and data sets that are often used by different programs. So we're talking about village lists, administrative divisions, medical warehouses, and so on. And often what we find is that these are maintained in silos. So different programs having their own systems to maintain them, kind of different update mechanisms, and so on. And really the concept of a common georegistry or CGR is to kind of bring all of that together into one place that serves as a single source of truth for geographic information. So this is where the Lao Ministry of Health partnered with Chai back in 2020 up until now, and back in the time that was the Department of Planning and Cooperation we worked with, and now kind of all things digital health are being transitioned to the Center for Health Statistics and Information. And that project was looking at just overall the access, management, and use of geographic information beyond just the health facility master list. So that included kind of improving the quality of existing lists and consolidating others where there was no master list available. Then also implementing data management processes where needed. So coming up with update mechanisms, kind of getting different programs to speak to each other, kind of to agree on how to standardize a list. Then there's also ensuring kind of that list gets hosted somewhere and then shared with other systems. And finally, also building some capacity in using those master lists for geospatial analysis and so on. Now, the Lao Ministry of Health selected GeoPrism Registry as the digital platform that would serve as the common geo-registry for the country. And just at a high level, so GeoPrism Registry at the moment is the only tool that completely implements this common geo-registry specification. So that is a specification that kind of was developed by the Health GeoLab Hub together with input from other partners. And this platform kind of can host, manage, and share kind of various lists. And alongside that, also the geospatial data associated with it. So coordinates, polygons, let's say for admin divisions, and also persist that information and maintain it through time so that there's also the possibility to pull historical data out of it. GeoPrism Registry is an open source platform. So the software development company behind it is Terraframe, based in the US, and then Health GeoLab, Chai, and others. And of course, also there has been a lot of input from the Lao Ministry of Health, have contributed kind of to its iterative design. And Laos is the very first country to have implemented this software. And at the moment also we have Chai in Mozambique supporting a pilot of implementing this platform at the cross-sectoral level. So just to briefly explain a little bit about the functionality, I know some of the screenshots may be a little bit small, but there's a host of things that GeoPrism Registry can do. I mean, there's direct feature editing, kind of with a kind of on a map-based platform where you can maintain current and previous versions of attributes. So for example, if there is a name change, like Dr. Visith mentioned as an example, we can add that in and store that with a start and end date for the validity period of that value. There's also list curation that can be done. And one of the most recent features of the software is actually a built-in public front end. So for example, in Laos, the health facility master list is entirely public, and people can go and download the health facility master list as in list or shapefile format from the public GeoPrism Registry software. Then there's also multiple hierarchy management. So health facilities, you know, they can be in an administrative hierarchy, they can have a reporting hierarchy, or for example, a health center can report to a district warehouse or a provincial warehouse. So that can all be maintained in there. And finally, there's also system synchronization options. So there is there's a built-in interface where you can link GeoPrism Registry up with DHIS2 and other tools like the Reveal precision platform. Now, GeoPrism Registry is getting quite a bit of recognition globally, especially since the release of the stable version 1 late last year. So it is recognized as a kind of a digital public good by the Digital Public Goods Alliance. Also, it's been recognized as a global good for health, and also kind of referring back to what Rita mentioned earlier, GeoPrism Registry is recommended as a facility registry tool for the OpenHIE reference architecture. Now, about the implementation in Laos. So in the live GeoPrism Registry instance, there is, of course, the health facility master list, but there are also kind of the province and district lists, and the most recent list that has been added are the medical warehouses. And other lists that are in progress to be added are kind of a set of village lists and also a village malaria worker master list. And as of very recently, and as I mentioned, because all of the responsibility over digital health is being transitioned for the Center for Health Statistics and Information, CHI has supported training a core group of staff at the center in list maintenance using the platform, and also soon will be training the center's IT team in kind of server management and installation of the system, because we're planning the migration of GeoPrism Registry from the cloud, where it's currently in, to a local server, just to increase Ministry of Health ownership. Okay, so this is my penultimate slide. So just to show how GeoPrism Registry fits into the digital health ecosystem. So kind of that update mechanism, so the one with the formal request letters and so on, where the provincial health offices provide updates to the Center for Health Statistics, that is still in place. But the actual updates to the list, those go directly into GeoPrism Registry. They then get synchronized with DHIS2, which is the National Health Management Information System for Laos, and kind of looking ahead to the future, because as part of the digital health strategy, Laos is looking to move towards an OpenHIE-based digital health architecture. A GeoPrism Registry is also compatible with the FHIR standard, or fast healthcare interoperability resources. And of course, there is a REST API available for other systems as well. So once there is kind of an interoperability layer or a health information exchange in place, GeoPrism Registry can easily plug into that. Okay, well, thanks everyone for your attention. So if any questions, Dr. Visith and I would be very happy to answer over email. But if you'd like to learn more about GeoPrism Registry, there's also the website available for you to have a look at. Thank you.
Thank you, Dr. Visith and Ms. Rita. I think we can have a few minutes for an open forum. So I would like to hand over the microphone to our moderator, Dr. Chaminda.
Thank you, Cha. So I think it's a very useful discussion, presentations that we had today on this Africa-Asia Digital Health Knowledge Exchange. And we were lucky to have Ms. Rita's introduction on the community, as well as the history about the facility registries in the OpenHIE ecosystem, in the Laos examples we had. We can move on to the questions and answers. Ismet Suleiman, it reads, hi, everyone. I want to ask about the process behind the registry. I feel before one decides on the tool, the process of registration must be in place, and for example, new facility, closing facility, upgrade facility, etc. Some of the slides of Biruhtesfa, Abere, he showed some of them. Would you like to give a bit of further explanation, as well as are these documents available online, the processes? I think there were a couple of flow diagrams as well.
Yes, we actually can share with you the slide in a PDF format, so that you can have the access to the files.
And the process you are following, has it been so it has been approved by the Ministry of Health and informed to the the local levels, as well as I think you were talking about a licensing system.
Yes.
So has it been in play? Are you doing the developments, or have you piloted, or in which stage it is going forward?
Yeah, almost to be launched. We are finalizing few steps, and almost to be finalized and to be scaled up.
Thank you very much for that information, and I think that that's very important. Like, that gives that validity and the motivation for people to go and update the system, and it's a very good lesson for those who are planning to implement such a system, or to upgrade it or improve the data quality. In the absence of questions from the participants, can I ask something? We had a recent connectathon in Sri Lanka, where we started exchanging patient demographics across our EMRs, syncing it to a shared health record. And one thing we noticed is, like, if you are using HappyFire in the default configuration, you would need the facility information or organization resource already stored in the shared health record for it to be referenced, say, for instance, as the managing organization of that patient's medical record. So does any of these implementations have a way of submitting or syncing its data with the Firestore, or is it just you have to configure it so that the Firestore will need to query the facility registry for existence of that data? It's quite a technical question, but if possible, I hope somebody can answer.
Yeah, I may have answer to this, not maybe in a very great technical detail, but what the discussion that we have been having with Sri Lanka MOH on exactly this. So they wanted the facility data with the lookup API, which the EMR can pull data out of for all the facility resource. We have that resource in FHIR, right? So they wanted that whenever we are building, or they are leveraging Sunbird RCs to build the schema for facility registry, that should be FHIR compliant, and they had also shared the mappings with it. And they are also in the process of publishing the fire profiles for facilities. So the plan that has gone there is that whenever they implement the facility registry, which will ultimately have all the information about the facility, the attributes, and it will follow the compliance, the data type, format requirement as per an FHIR profile that the country is going to publish. Whenever anybody pulls the data or requests facility data, it will always come as a FHIR JSON. That was the plan that they have been having in place to cater to the problem that you just mentioned.
Thank you, Ms. Priyanka, for the explanation.
I think there are no more questions from our participants, Dr. Chaminda. We will try to send the contact information that was left in the chat box so our participants can ask their questions later on if they still have any. So thank you, Dr. Chaminda, for moderating the session. Before we wrap up the session, I would like to call on our chair, Dr. Bunsay, to give the closing remark.
Thank you, everyone. And I really, this session is very, very good, and we have learned a lot from that. There are so many tools and technology that is open as a global goods right now. I would like to kind of emphasize that whatever the registry that we do, the challenge, the biggest challenge, it might be not the technology, but the people, the governance of the system. This is have to have this registry to get the interoperable system, but to populate, like our friend from USAID said, that it is very difficult kind of to governance, to create the master facility list and hierarchy and the taxonomy related to that. So it's good that we learn that there is a lot of software technology and many approach that we can facilitate our or leapfrog our development. But the big challenge is how we're gonna create those kind of the master facility list that and maintain it and standardize it. That is the big challenge. I think we learn a lot from that. Thank you very much. And I think this kind of the forum is good that we have exchanged the idea from different region and we learn more on that. Thank you. Thank you and goodbye.